Our group has been working on developing CAR therapy for hematologic malignancies and focusing on lymphoid malignancies targeting CD19. And to put this just in very quick perspective, what I'm going to be presenting later this morning is our work targeting CD19 on both CLL, chronic lymphocytic leukemia, and on ALL, acute lymphoblastic leukemia. And it's important because while CLL is a chronic disease, we talk about median survivals of maybe 10 years, but it could be anywhere from 1 out to more than 20 years. We can predict prognosis, and we know for patients who are relapsed after conventional therapy or who are refractory to conventional therapy, their prognosis is dismal. There's no curable therapy other than allogeneic bone marrow or stem cell transplant, which is fraught with extensive morbidity and mortality, and clearly we need a more effective therapy for these patients. Many of the mechanisms for resistance to CLL are known, and anything that we develop to try and treat these resistant patients have to be able to bypass these various resistant mechanisms, which I'm not going to dwell on. In ALL, in acute lymphoblastic leukemia, the most common leukemia in children and about 25% of all acute leukemia in adults, we know that prognosis for patients who relapse or who have resistant diseases is equally dismal. Their median survival is less than a year. Allogeneic transplant for patients who are refractory is largely ineffective, and the majority of these patients will die. And there's been this desperate need to develop newer, more effective therapies. And the rationale for using targeted cell therapy is that it can bypass many of these resistant mechanisms. And using these genetically modified targeted T cells that we're going to talk about has the advantages of all different types of cancer therapy. It combines the advantages of antibody specificity, so that antibody therapy by providing targeted specificity. It provides the advantages of cellular therapy because as a living product, this can grow, divide, and proliferate and amplify the response. And it provides the advantages of vaccine therapy because if these cells persist, you can get persistent memory over long periods of time, in fact. And we are targeting CD19. And if I can advance the slide, how do I do that? Oh, we can just click. So we're using these chimeric antigen receptor modified T cells that the CARs, the chimeric antigen receptor, combines this antigen recognition domain of an antibody with an intracellular signaling domain that signals the T cell to become activated, to divide, and to kill into one single chimeric protein. And using gene transfer technology with the lentivirus vector, we can stably express these CARs on the surface of T cells, and it confers this novel antigen specificity. And if you advance one more, you can see now that it has the specificity, it can engage its target, in this case CD19, on the surface of a leukemia cell, and click one more time, just leading to death of the leukemia cell. And Rainier Brenchens, who's going next, actually, we were talking about, really provided the framework of this slide for me, so I thank him for that. And if we can skip to the next slide, really, this is the bottom line of the work we're going to present, which is a clinical update using our CART19, or what's now referred to as CTL019 cells. We have evaluable responses in 17 patients with CLL, with major responses in 10 of these patients. So almost 60% have had major clinically meaningful responses. 5 of these have been complete remissions, 2 of them now sustained beyond 2.5 years. 5 have been major partial responses, with at least, in fact, 3 of them now still ongoing responses over periods of time. In ALL, we have evaluable data. While we've treated 11 patients, we have evaluable data in 6. 5 of those 6 patients achieved a complete remission. Now remember that all of these patients have far advanced refractory leukemias with very few effective treatment alternatives. 4 of the 5 children treated with ALL, with refractory ALL, have had complete remission. Our first adult treated has had a complete remission. What we have seen is significant toxicities. All responding patients have developed what we refer to as a cytokine release syndrome. We have been able to treat that effectively with anti-cytokine therapy, What we don't know is yet when the appropriate timing of that intervention will be and whether or not anti-cytokine therapy abrogates the response, but that's something we're working very hard to develop. These patients develop on-target toxicity, meaning their normal B cells are also ablated and they develop B cell aplasia. But what we have seen is massive expansion of these T cells, 1,000 to over 10,000-fold expansion of these cells, which we think is critically important to amplifying the anti-cancer response. We've shown that they can persist beyond 2 years and provide memory activity. These cells that persist are actually still biologically active, and we've shown that in the lab. For every cell that we infuse, we've done calculations showing that they can kill between 1,000 to 93,000 cancer cells and have the ability to eradicate between 2.9 and 7.5 pounds of tumor. Our trials are ongoing. We have further studies in progress and in development. We're trying to define the optimal timing of therapy, the optimal cell dose, and trying to determine criteria that may predict which patients will and won't respond, and trying to amplify the response for those patients who it's so far been ineffective. And it would be rewarding, actually, if this type of therapy could someday actually replace the alternative, which is the only available cure, which might be allogeneic transplant.
To highlight a bit more now that I can use part of my time to illustrate what these chimeric receptors are really made up of, it's a kind of a Frankenstein-like molecule where you take a piece of an antibody, which you can clone out, which recognizes a particular target, in this case CD19, and you can fuse that genome to the signaling domain of a T cell receptor. So it's a Frankenstein-like molecule which surprisingly works quite well. And the gene that you generate in the laboratory for that can be put into either a retroviral or lentiviral vector. And then that vector can then be used to infect a T cell that would otherwise ignore the tumor cell, but now expresses this receptor. And this receptor can now identify and target the target antigen, in this case CD19. And CD19 is an interesting target because it's only otherwise expressed on normal B cells. And so if you successfully target this, the worst that can happen to the patient is that they lose their B cells. And that is something that can be clinically managed. And therefore, it's an attractive target. It's also attractive because it's expressed on a variety of B cell tumors. And these B cell tumors would include chronic lymphocytic leukemia, which is a low-grade tumor, as David pointed out, or the much more aggressive acute lymphoblastic leukemia, which certainly in adults has a very, very poor prognosis. And in pediatric patients, if it relapses, has a poor prognosis. So I basically have a slide. I have one more after this just to show some pretty pictures. But we treated 5 patients with acute lymphoblastic leukemia. These are all patients that had been treated initially, went into remission. And after they were in remission, sometime during the predicated 2-year course of chemotherapy thereafter, the disease came back. And if you're an adult and you have B-cell acute lymphoblastic leukemia and your disease comes back, your prognosis is dismal. So these are very desperate patients. In the protocol, what we decided to do is we would treat these patients with what we call salvage chemotherapy, which you would ordinarily do, and then if possible, you would send them for transplant, for an allogeneic bone marrow transplant, which, as David pointed out again, is fraught with a lot of morbidity and mortality. So the overall outlook is quite poor. And in fact, I would point out that of these patients that were treated in this fashion, 2 of these patients in particular, even after getting further chemotherapy, their bone marrows were still packed with tumor. And by now, there's absolutely nothing we have to offer these patients except experimental therapies. And this was a protocol that they signed up for. And so they received these CD19 targeted T cells that are allogeneic, or rather that are autologous to their own cells. So they're their own T cells that were pulled out from the blood, modified, and infused back into these patients. But I'd also point out is MRD stands for minimal residual disease. So of the 5 patients that we treated, 2 had overt disease, and 2 of them had what we call minimal residual disease, which is to say they can still detect the cancer in the blood, even though the bone marrow looks like it's in remission. These patients similarly do not do well when going into an allogeneic bone marrow transplant. The result of treating these 5 patients was that all patients no longer had any detectable disease, even by what we call deep sequencing, which is a highly sensitive methodology of trying to detect the residual tumor cells. And so all of these 5 patients, 4 of them went on to allogeneic bone marrow transplant, which was which is the standard of care for these patients. 3 of them are alive and well today. 1 is 2 years out from treatment. 1 patient died of a pulmonary embolus, but was in remission at the time of treatment. And 1 patient ineligible for a allogeneic bone marrow stem cell transplant ultimately did have relapsed disease. As David pointed out, there is some toxicity associated with this therapy. It's called a cytokine storm. When these T cells become activated, the patients develop what would normally happen in, say, fever. They get high temperatures, their blood pressure can go down, and their heart rate goes up. We initially sent our patients to the ICU for this. Having better managed this now on the floor, the patients are much better tolerant of this, and we think that this side effect can be largely abrogated by simply treating patients when they don't have as much disease on board. And so in the last slide, I'll just quickly show you this picture. These are the 2 patients that had overt disease. If you can see here, all these cells look the same, and they all look the same because they are the same. They're all tumor cells. And by as early as 8 days out, there no longer is any more detectable tumor cells in the bone marrow. And by 1 to 2 months afterwards, what you see here is a heterogeneous population of cells. This is what would be representative of a normal bone marrow after treatment with these modified cells.
So I'll be just giving a little overview of oncolytic virus biology and then some review of recent clinical trial data that we have been observing and future plans for our subsequent phases. So the general concept of oncolytic virus therapy is that normal cells cannot support the replication and infection by the oncolytic virus, whereas cancer cells, due to their biology, are a great host cell for infection, replication, and then subsequent tumor cell lysis and virus spread. What we've observed specifically with vaccinia biology is the ability to overcome particular hurdles in virotherapy. So we observe great potency. There are multiple mechanisms of action for the infection and treatment of cancer, and intravenous delivery is possible with a great safety record. We have been using JX594, which is a targeted and armed YF vaccinia virus strain. The thymidine kinase gene, which enables replication in normal cells, is disrupted, therefore creating the ability for selective targeting of cancer cells in tumor vasculature. And we've inserted LAC-Z for monitoring capabilities, as well as GM-CSF to drive active immunity. In normal cells, the virus is unable to really take hold and infect the cells, whereas in cancer cells, due to the loss of the interferon response and an overactivation of the EGFR-RAS pathway, leading to increased pools of thymidine kinase, the virus has an ideal environment to grow, replicate, producing viral factories, destroying the cell, and then spreading to neighboring tumor cells. We have observed 3 mechanisms of action. In addition to direct cell lysis, we also see active immunotherapy, where the patient's immune system is stimulated, recruiting other immune cells to the tumor site, as well as vascular tumor ablation. So far, we've treated about 200 patients to date. We observe great safety profiles with only mild flu-like symptoms for about the first 24 hours after treatment, and some cases hypotension. We are able to deliver systemically, both through intravenous as well as intratumoral injections, with great pharmacodynamic profile, anti-tumor activity observed, and improved survival. As you can see here, direct injection of tumors results in often dramatic responses, and even non-injected distant tumors also show response. Here we had complete response in a renal cell carcinoma patient, direct injection to the liver, but there was also complete response seen in distant non-injected tumors. We also observed that this result may be due to a combined activity of antibody as well as complement, and we see an interesting correlation here, actually just published yesterday in Science Translational Medicine, a correlation between survival and CDC response. And so this is an interesting correlation that we would like to follow up on. We also observe that the percent of patients responding is related to dose, as well as an inverse correlation in dose to recurrence of tumors. We also published recently, a couple months ago, in Nature Medicine, that there is a significant improvement to overall survival between a randomized high-dose and low-dose cohort, even after just 3 injections within the span of 1 month. And this is actually quite a significant finding, the first published randomized study showing significant survival due to a gene therapy. So next steps are to determine anti-cancer immunity, to look at combination therapy, and then also to move towards marketing. We are currently in the middle of a phase 2B study, and this will be reading out later this year, and we have plans for phase 3 hepatocellular carcinoma, head-to-head JX594 versus sorafenib.
Switching gears from cancer therapy, our target disease is hemophilia B. Hemophilia B is a hereditary bleeding disorder. It results from a deficiency of the human clotting factor 9. And the clinical manifestation or phenotype for these patients is frequent spontaneous bleeding, often in the joints, but occasionally within the central nervous system, where it can be fatal for these patients. So to be fair, there is current therapy, although it's largely inadequate for these patients. One can simply give back the missing protein, but this is really an inconvenient process because of its very short half-life. It has to be administered several times a week. It has to be administered intravenously, and so requires IV access for these patients. It's very expensive, and partly because of this, it really has limited availability worldwide. So there really still is an unfulfilled need for these patients. Gene therapy, however, offers the chance really to cure these patients with hemophilia B after perhaps just a single intervention. And the way to do that really is by transferring copies of the normal gene for factor 9 to the liver. These normal copies of the gene then serve as the template for synthesizing normal factor 9 protein. And in fact, the liver is the normal site for factor 9 synthesis. And through this, we can achieve correction of the disease and hopefully cure. Our vehicle for delivery of the gene, the vehicle that we favor, is this adeno-associated virus, or AAV vectors, because of both their safety profile and their ability to maintain long-term replacement of the missing gene. Next slide, please. And so we have undertaken over the last few years a phase 1/2 clinical trial of AAV-mediated gene therapy for hemophilia B. Thus far, 10 patients with severe hemophilia B have received vector, and severe hemophilia B is defined as factor 9 activity of less than 1%, essentially no factor 9 activity in these patients. It's a single IV injection that occurs over about 30 minutes. We had been admitting the patients overnight for observation, but that seems largely unnecessary, and so moving forward, this will be an outpatient procedure. The vector has been given at one of 3 dose levels. So as I mentioned, a dose escalation study. There were 2 patients in each of the low and intermediate dose cohorts, and an expanded cohort at the high dose of 6 patients. So it comprises a simple peripheral IV injection of our vector. This stands for self-complementary. It relates to the construction of the vector genome. AAV is the vector delivery system. We use an alternative serotype, serotype 8. Prior AAV studies had been done with serotype 2. This is our liver-restricted expression promoter system, so that expression of factor IX occurs only in the liver, even though some of the vector may get into other organs. And we have codon optimized the factor IX coding sequence to try to improve the efficiency of translation. So this slide summarizes the results, and more detail will be given at our presentation on Saturday. But as an early phase study, the primary objective was to assess the safety. And in fact, we found that peripheral vein administration of vector was very well tolerated in all patients without any acute side effects. Secondary objective, of course, included measuring the efficacy, and what we found was persistent, stable factor IX expression in all 10 participants. And so their levels of factor IX activity were on the range of 1 to 8%. Again, these are patients whose baseline is essentially 0. And I would say parenthetically that if you ask a clinical hematologist, that about 20% of normal activity is probably sufficient to really call these patients cured. So a little ways still to go in terms of thinking that the patients are cured, but nevertheless a good start. So this approach was efficacious. We saw increase in factor IX activity levels that was dose-dependent in all patients who received vector. This had a significant impact for these patients who were generally receiving prophylactic protein infusion 2 or 3 times a week. Even these modest levels of factor IX activity have allowed 8 of 10 patients to stop prophylactic therapy altogether, so a significant impact on their lifestyle. 2 of 10 didn't stop prophylaxis altogether, but it increased the interval between required administration of vector. The other important point is that this is really a lasting effect, and so for some of the earlier patients who have been followed for over 3.5 years, the new factor IX activity level has been stable. So for the early patient who got the low dose of vector, 1 to 2% factor IX activity. And then, though, for the high dose patients who've been followed up to 2+ years, factor IX activity of 4 to 6%. There was some evidence of immune reactivity to the vector, manifest by some inflammation of the liver. This was easily controlled with a very short course of steroids, and those patients, in fact, were able to maintain their factor IX activity level.
So this is a long name. It's aromatic L-amino acid carboxylase. This is a congenital disease. It's a very rare disease. And this enzyme, although the name is not familiar, it's responsible for the production of dopamine and serotonin. And we know that these 2 neurotransmitters are very important, especially this dopamine is also responsible for the production of norepinephrine and epinephrine. Dopamine actually is a neurotransmitter in our brain, so you can remember that it's Parkinson's disease, it's a dopamine deficiency. In the brain, the dopamine gets several pathways, and the most important is a pathway from midbrain to putamen. And this pathway actually controls our movement. So those patients, they have congenital deficiency of dopamine in their brain, so they have a very severe hypotonia, so they don't move, and when they try to move, they have a very severe dystonia, and also have this rhythmic oculogenetic crisis, and they also have autonomic system dysfunction, and most of the patients will die at the age like 5 to 6. They are not responsible to medication because dopamine doesn't get into the brain. So the best way is to try to do gene therapy, and this vector has been tested in the gene therapy for Parkinson's disease. The way is that we inject the virus into the brain, and the target region in this trial is into the putamen. So next slide. Okay. So currently, this trial is done as a compassionate use, and we have previously published the result of 4 cases, and now we stand to 8 cases. The surgery was done at the age of 2 to 8, and we have followed them with duration of 1.5 years to 3 years. You can see over here it's a motor scale, and before the start of the treatment, they really have nothing, and almost for everyone they get a good progress. We have other objective measurements that we can prove the effect of this treatment. For example, this is a F-DOPA PET. So if we express the enzyme in the brain, then the enzyme can convert DOPA to dopamine, and the dopamine will be retained in the brain. You can see this is pre-treatment and 6 months after treatment. The other part also show very beautiful expression of this enzyme. I just show one picture from our first patients, and this is before treatment at the age of 4.5, and she cannot move, have no head control, can do nothing, especially except this crisis attack. And this is picture 2 years after treatment. She can stand with support because of previous complication with the back, so she cannot work at this moment. So in summary, from the 8 cases, and before the treatment, none have head control or anything else. And after treatment, 7 patients get some head control, and now we have 4 patients, they can sit without support, and we have 2 patients, they can stand with support.
Good morning. Our group is interested in developing better treatments for recurrent ovarian cancer. And ovarian cancer is the most lethal gynecologic malignancy. 16,000 women die each year in the United States of this disease. So based on preclinical data demonstrating significant anti-tumor efficacy in a variety of ovarian cancer models, we moved on and translated this novel approach using engineered strains of measles virus in the clinic. The strains we are using are actually cousins of the vaccine strain we normally use to vaccinate our children against measles, so there is an excellent safety record with millions of doses having been administered. But what we're quite interested after we give the virus to the human is to also to the patients is also to understand the fate of the virus. And for this reason, we have modified the strains to express the sodium iodine symporter, or NIS gene. NIS is a normal human protein, is overexpressed in in the thyroid gland. So as a lot of you know, we can actually use iodine isotopes both to image the thyroid and treat thyroid cancer. And the reason we can do that is because thyroid cells express this exact protein that our viruses also express, the NIS protein. And that's how we envisioned it to work. we give the virus in the modified measles virus in the peritoneal cavity of the women with recurrent ovarian cancer. The virus finds the cancer cells and replicates, very specific for cancer, and we'll discuss the reason for this specificity. After the virus replicates in the cancer cells, viral proteins are expressed, and the NIS gene that is now part of the virus expresses itself as well and finds its way on the surface of the infected cells. So then we can use iodine-123 imaging and SPECT-CT scanner to image the distribution and proliferation of the virus in the human, as in this example where you see the virus replicating in metastatic ovarian cancer deposits in the pelvic area of this patient with recurrent ovarian cancer. Now, the study eligibility was such that patients should have failed all standard treatment in order to be eligible for this approach. That means that they have failed taxanes, platinum, which is the standard treatment to treat recurrent ovarian cancer. And in this context, the median overall survival of 26.6 months we observed in these patients with recurrent ovarian cancer, we believe it's very promising. As a matter of fact, if we look at this number in the context of other contemporary studies with novel therapeutics, including agents such as bevacizumab, which we know they do have activity in recurrent ovarian cancer, it is actually comparing favorably, since but even bevacizumab for patients who have failed taxanes and platinum for recurrent ovarian cancer leads to a median overall survival in a range of a year to 16 months. And these patients were heavily pretreated. So the average patient in the study has had 4 chemotherapy regimens for recurrent disease. So truly, they were entering the final stage of this disease. And despite the fact that this is an early trial, we feel the data are very promising and merit prospective validation. So why is measles a good platform for ovarian cancer? Well, the reason is that ovarian cancer overexpresses the 2 of the 3 receptors of the virus. The CD46 receptor, brown staining, this positive staining in the tumor for ovarian cancer patient, because it helps ovarian cells escape complement-mediated lysis. And the newly identified receptor, Nectin-4, for the virus is also very expressed in ovarian cancer. How does the virus work? We think there are 2 ways. One is by truly replicating and killing cells. The second is by eliciting an anti-tumor immune response following oncolytic cell death of the cancer cells. Indeed, we did immunologic analysis in a subgroup of patients in our trial, and we did observe a robust activation of anti-tumor immune response. Actually, that also explains why we saw most activity in patients who had lower volume of disease when they received the virus, because the immune system then could eradicate much better the residual tumor. So where we go from there is 2 follow-up trials. One is a randomized phase 2 trial comparing MVNI's viral therapy to the oncologist chemotherapy of choice. What I did not mention is that this treatment is very, very safe with minimal toxicity, only grade 1 and 2 mild abdominal pain and fatigue being the most common toxicities. This, of course, is much better as compared to significant toxicity associated with chemotherapy in this patient population. So our hypothesis is that this treatment can improve outcome at the expense of less toxicity, and this randomized phase 2 trial is going to allow us to test this hypothesis. Last but not least, we're going to be activating another trial this year where we're looking at ways to deliver the virus to the tumor even better. And the way to do that is by using adipose tissue-derived stem cells. So stem cells that we actually grow from the fat tissue of the patients with ovarian cancer. And we have found in the laboratory that these cells can home the virus and take it to the tumor site and protect the virus from the immune system. So we have received approval from the FDA to perform, actually it's going to be the first in human trial, where a stem cell platform is used to deliver oncolytic virus in cancer patients. Thank you.
Thank you, Eva. Click ahead. This disease is a form of muscular dystrophy with a very severe early onset, and in fact, historically, patients did not survive past 1 year of age. Now there is an additional treatment available through protein replacement or enzyme replacement therapy that has really altered the natural history of the disease, and we now faced with an increasing number of patients who have partial treatment like this one shown here, and some of the late manifestations of the disease, if you go on to the next point, you'd advance, are that there's motor function despite the treatment with the enzyme replacement therapy that affects the heart, next, all of the muscles in the body, so this is its aspect in muscular dystrophy, and last slide, last point, the respiratory system. So in the patient population, we see progressive loss of independent ventilation and use of the mechanical ventilator like shown here. The study we conducted was to evaluate the safety and efficacy of a gene therapy agent delivered to the diaphragm and motor neurons that control diaphragm function. And we did that by a surgical delivery technique where the diaphragm was directly dosed with the vector and in turn the motor neuron that controls diaphragm function. So we had to evaluate both the safety of the procedure and the potential impact on respiratory function, keeping in mind that in this patient population there was progressive loss of ventilatory function, certainly also facilitated by the fact that the patients are using full-time assisted ventilation. So if you go on to the next slide, what we found, which was quite remarkable because of the incomplete treatment from the existing therapy, that all the patients that we studied throughout 1 year of this study actually gained respiratory function as assessed by spontaneous ventilatory endurance, in which we actually separate the patients from the ventilator and look at their increased ability to breathe on their own. Of course, this has an important safety factor, and it is a step towards them receiving a separation from the ventilator and breathing more independently. So as we move on with this study, we're looking at approaches to increase dose and change the dosing route to a more systemic approach where we can impact both not only the ventilatory function, which was readily measured by the techniques we used in this study, but also look at other aspects of their motor function. So like in other muscular dystrophies, the focus will be on total body correction. So that's where I think the field is moving. We see an opportunity to move from local to regional to systemic dosing strategies, which will have, I think, a major impact in patient populations like this one.
Dr. Glampia, I missed it in your presentation. Can you go over why adipose tissue-derived mesenchymal cells are being used?
Yes. So the way we currently give the virus is by diluting the virus in normal saline, and then through a portacath, which is very similar to the one we use to administer intravenously drugs to patients, but that's a specially designed catheter for peritoneal administration. We deliver the virus over the course of 30 minutes. So what happens if you give normal saline in the peritoneal cavity of a patient, the kinetics are such in about 3 to 4 hours, all the solution is absorbed. And that means that the virus finds its way to the circulation where it will likely be inactivated by antibodies against the virus. So these results that you saw were even with these limitations in delivery. So we hypothesized that if we have a way to force the virus to stay in the tumor environment for longer, then the results will be better. And the mesenchymal stem cells do have the natural propensity to home to tumor sites. And there are different kinds of mesenchymal stem cells in terms of their origin. some, we can grow some from adipose tissue. We can also grow mesenchymal stem cells from the bone marrow. We don't necessarily know that these are interchangeable for the purposes of this application. So for example, the same virus, if we want to target a hematologic malignancy, we might want to use mesenchymal stem cells deriving from the bone marrow. But for this purpose, actually, we can, one of the characteristics of the cells that we use is that they need to be infected by the virus at a high enough percentage, but not die immediately, because we want 1 to 2 days for the cells to stay in the tumor environment, so then the virus can be delivered by a process we call heterofusion. The cells will eventually fuse, reach the tumor environment, and there they express viral proteins on their surface. The viral proteins allow fusion with the tumor cells and delivery of the virus to the tumor cells. So we have done extensive preclinical work with this approach, and that work showed that by doing so, first of all, we accomplish a very effective homing. The second is because the cells are carrying the virus, that the virus is protected by the impact of the immune system. So that's the rationale behind that. So for patients with low burden of disease, that's not as much of an issue. We saw very significant efficacy there, and that's why our randomized phase 2 trial is limited in patients with low disease burden. When you start having, though, a larger disease burden, then better viral delivery, we hypothesize, might lead into better outcomes.
What is back? No. So you, the two of you reported this very exciting use of engineered immune cells to kill cancer. They kind of go into the patient's body and do a what I characterize as a seek and destroy mission of the cancer. Very exciting, and you reported wonderful clinical progress. I was wondering, is this kind of technology can be broadened to be used to target solid tumors and so on? I mean, it's very exciting.
I think that the most important relevance, besides obviously treatment for patients that have CLL and ALL, of this data is that it's proof of principle, that T cells can be genetically re-engineered to target tumor cells, and that they can actually induce a very significant anti-tumor effect. But as everyone involved in the field knows, there is this concept of a tumor microenvironment, which is very immune inhibitory. So it's possible, for example, in solid tumors to generate massive amounts of T cells specific to the tumor, and yet the therapy may fail because the tumor is protected against immune attack by such mechanisms as regulatory T cells, myeloid-derived suppressor cells, PD-L1, CTLA4. These are all agents that the tumor scaffolds itself with to protect itself from the immune system. And so what is going to be necessary, I predict, is that there is going to have to be further adjustment and tweaking of this technology to make it successfully applied to solid tumors. I think that we will absolutely get there. And there's several ways that you can protect these T cells, and we call them armored CAR T cells that secrete cytokines or ligands that can reverse this hostile microenvironment. So, you know, there's a reason why everybody's doing CD19, because it's an attractive target, and it's a hematologic malignancy which may be easier to treat. And conversion over to solid tumor is definitely ongoing as we speak, but will likely, in my opinion, require further modification to make the cells a bit more potent.
Okay. All right, thank you. My next question would be for Dr. Davidoff. You reported very exciting clinical progress that the hemophilia B patients are expressing 1 to 8% of factor IX, which is, if not curative, as you say, you did 10-20%. You have major clinical benefits for these patients. So, and it's persisted for several years after a single treatment, and that's really what we dream about when we talk about when the field of gene therapy was born 20 odd years ago. This is the kind of results that we dream about. So we're finally seeing it here, and I was wondering, what do you have in mind in terms of trying to get it working even a little bit better so that we can call it a cure?
Well, I think it will take a combination of strategies to bump that 8% up to 20%. There are always ways to engineer the expression cassette that potentially can lead to improved transgene expression, in this case factor 9. There are also things about the vector preparation that we have learned recently are trying to fix. So, for example, the preparation that those 10 patients received had a significant percentage of empty vector particles, so they had the vector protein coating, but didn't have the vector genome within them. And so by modifying our production methodology, we have improved that percentage to closer to 90%. And so on a per particle basis, we expect to get a better result. Of course, in some ways, the simplest thing is just to give more vector, and that's always possible. So there are a variety of somewhat simple and more complex ways of adjusting the vector design, vector preparation, and so on to try to shoot for something on the order of 20 to 25%. I think that's very achievable.
All right, well, that's really great. We look forward to hearing more progress. I mean, but yours really present what your presentation really is. It's a platform technology that can be utilized to treat all sorts of metabolic diseases in the liver.
Yes, both primary diseases of the liver, but also to serve as a site for synthesis of other therapeutic proteins. Yes.
Wonderful. My next question would be for Dr. Wasserman. You reported 200-some patients treated with this oncolytic vaccinia virus. That's a lot of patients. And you're reporting very nice results in high journals, Science and Nature Medicine, and so on. So I'm just wondering that what does it take for this product to go forward so that one day it might be registered with the FDA?
Yeah, that's a good question. So currently the standard of care for our lead indication of liver cancer is to treat with sorafenib, and that is currently the only FDA-approved product on the market. I think a big hurdle will be to show a comparison between the currently approved product and our product, the oncolytic vaccinia virus. So that's why we have plans for a phase 3 to have a head-to-head comparison of sorafenib versus the oncolytic vaccinia.
And when is that phase 3 going to take place?
We're currently in the planning process. We hope to begin it sometime next year.
Okay. Thank you very much. Dr. Hu? Yes. You presented this picture that was so impressive. The infant cannot move into somebody that to them was able to stand up. I was really struck by the image. So you say you've done 8 patients. These are all compassionate uses.
Currently.
And so do you see what kind of progress do you hope to accomplish in the next few years for this particular disease, and are there other neurological disorders that you'll be thinking about implementing this technology to?
Yes, I think the study is difficult because this is a very rare disorder and there's no exact animal model at that time. So basically we follow this Parkinson model, but they use the same vector and the same injection technique. But with this very good experience, I think now we have enough evidence and we have make a larger production done by University of Florida that we are going into a real clinical trial, and I expect that this trial will be very smooth. Actually, this story is not a surprise because there's disease we call the dopa responsive dystonia. So this is some rare story that you find a CP patient, cerebral palsy patient, age of 5, and you give him or her DOPA, and 2-3 years later they stand up. Yeah. So we just replicate this story to a disease that previous that cannot be treated by DOPA or any of these effective easy medicine. I think from my story and a few other stories in the meeting that these vectors are actually very effective. So if we really choose the genetic disease that we know the genetic defect is very clear, and at this moment, if the treatment can be done by local treatment, so we have this CNS injection, we have an eye injection, ear injection. All these treatments are very effective, and actually they are very safe. I believe that there will be many other genetic disorders that can be treated by this platform or this kind of gene therapy.
Great, thank you. Dr. Burns. Muscular dystrophy or Pompe's disease is a very serious disorders, and I'm really struck by your progress going from local administration to kind of thinking towards systemic delivery, so that you could deliver the gene, the corrective gene throughout the whole body, and that's really exciting. I'd like to hear some more about your thoughts about how do you bring it from this point on forward.
I think in many ways, like the other examples here, we develop proof of concept in appropriate models, do early phase clinical studies, and then work forward towards really more global correction of the problem. And we know that in a lot of the conditions that are metabolic diseases or affect all the musculature, that global correction is ultimately a requirement to a real clinical benefit. So this is part of the development plan for the program, and one of the key points, I think it's true for all biologics, is the manufacturing, and the vector has been a critical part of developing a method for producing enough material to give systemically to humans. And so the early manifestations of this disease actually favor dosing in infancy, and certainly, in fact, the work that Paul has done in Taiwan is pioneering in that newborn screening is ultimately an expansion of the expanded panel to other diseases like muscular dystrophy will enable us to treat patients pre-symptomatically at a young age and favor that dose to body weight ratio, and that I think is one of the strategies we're going to pursue in this condition. So,
Great, thank you.